Our next speaker is Dr. S.S. Pandav, a glaucomatologist of a great standing in our country, professor of ophthalmology, PGI Chandigarh, and president of GSI. And he is going to be talking on raised intraocular pressure after trauma. I think something very, very relevant for a comprehensive ophthalmologist of the country. So let's hear all the essentials from you.
Thank you, Dr. Chitra, first of all, and ARC for including me into the program. Raised IOP after trauma is a complex situation, and very often we find it because this is quite common after blunt trauma particularly. So I'll be talking more in relation to blunt trauma. And if you look at the literature, about 3 to 4% of these patients, they end up with glaucoma in about 6 months' time. But if you increase the follow-up to 10 years or so, almost 10% of these patients, they would have glaucoma. Now, this is, I'm talking the real glaucoma. The ocular hypertension or the high pressure without producing glaucoma is much more common. And that is actually very important to understand because we can prevent this glaucoma from happening. So important issue is, can we predict who is going to get high pressure? So again, there's no sure way, but some of the indicators which could tell you that the person is going to have high pressure or glaucoma later on is that if the presenting visual acuity is worse than in the 20/200, presence of hyphema, lens injury, angle recession. So these are the 3-4 factors which are important. And if they are there, these eyes would be at a higher risk of developing high pressure and subsequently glaucoma. The clinical features are quite complex. It depends on the severity of the injury and what are the other associated injuries are there. But essentially, most of these patients would have hyphema. And the presence of hyphema basically indicates that there is a significant amount of injury inside the eye, and one need to be more careful. Therefore, it is very important to characterize the grade hyphema. This could be microhyphema or that could be full chamber hyphema, because this will help you monitor the progress of the case, and also it has a relationship with development of glaucoma subsequently. So the likelihood of glaucoma increases if the proportion of the hyphema is higher. So if you have a hyphema of say, about less than 50% of the anterior chamber, then about 10% of these eyes would have high pressures. But if it goes to more than 50% or to 100% or full chamber hyphema, the percentage of these cases developing high pressure and subsequent risk of developing glaucoma goes to 25 to 50, even 50%. But overall, if you look at the average, about 30% of the patients who have traumatic hyphema would have high pressure subsequently during the course of their treatment. So this is a 29-year-old male who had a shuttlecock injury and came with the IOP of 58 millimeters of mercury, and visual acuity was down to 3/60. Now, there's not much of hyphema here. You can see this cornea, hazy because of high pressures. There's a hyphema, but not as much. You can see the iris, some of the iris details are still visible. So if the patient is coming early at this stage, we would assume that this is more because of the trabecular injury and maybe inflammation in the trabecular meshwork, which is leading to high pressure. So we would treat this patient with steroids, and of course, we reduce intraocular pressure. But sometimes these cases could be very intractable, like this one. Actually, the IOP didn't come down with any of this treatment, and we had to give IV mannitol repeatedly for this patient to keep the IOP under check. And even that didn't work for this patient. With the pressure, IOP would go up, within a couple of hours after the mannitol effect was over. And we had to do paracentesis 2 times at least for this patient, which removed the high blood part of it. There's no hyphema now, but the IOP still remains high, and this is the situation, say 5 or 6 days down the line. So eventually we ended up doing trabeculectomy for this patient, and this is about 3-4 weeks down the line. Now you can see the IOP, the cornea is cleared, and the anterior segment looks much better. And also there's a diffuse in the IOP of 8 millimeters of mercury. So sometimes even small amount of hyphema can actually lead to a very intractable kind of glaucoma, and you might have to do surgery for these patients. So this patient had acute rise in IOP, and most of the time the acute rise in IOP would be associated with hyphema, injury to trabecular meshwork, inflammation in the anterior chamber, or if there's a vitreous collapse in the anterior chamber clogging the trabecular meshwork, or lenses are subluxated to the anterior chamber. So these are the patients who would need urgent treatment. So indication for surgery in hyphema are well documented in literature, and there are different guidelines. But to to give you a quick and short remembrance is that anytime you have a IOP of more than 50 millimeters of mercury and is persisting more than 4 or 5 days, there's an indication for removing blood from the anterior chamber. Or if you have a IOP of 35 millimeters of mercury, which remains there for 7 or 8 days, we have to go in and remove the blood. Here, there are two things which are important. One is the optic nerve, of course, which is from glaucoma point of view is important. So you have to protect the optic nerve. And also there's a corneal endothelium or the corneal blood staining. So you have to also consider the health of the optic nerve if known before trauma, and also the status of the endothelium. And these timings are likely to be, should be modified according to the situation. So this is 23 years old male person who had a trauma, and he came after 3 months. So here the presentation is a bit delayed, and you can see the vision is down to counting fingers, and the pressure is 56 millimeters of mercury. So on examination, you can find there are sphincter tears and pupil is irregularly dilated. The important thing was that there was a lot of pigmented cells. You probably will not see on this picture, but there were a lot of pigmented cells there in the anterior chamber floating around. There's a bit of cataract, and the fundus glow is, there's a good glow, but you can't see the details. There's a yellowish kind of a glow, but you can't really see any fundus details. So there's a vitreous hemorrhage in this patient as well. So here in this situation, and you can see the angles are open. There's a little bit of suggestion of angle recession perhaps in one quadrant, but by and large the angle is open and preserved. So here the diagnosis would be a host cell glaucoma. So when you have vitreous hemorrhage, and when the RBCs they degenerate, they become spherical, they lose their biconvex shape and they become spherical, and they appear brown or khaki color, that they could be seen in plenty in the vitreous as well in the anterior chamber. Now they actually migrate to the anterior chamber, especially if there's a break in the anterior hyaloid phase, because that facilitates their migration. And this takes about 1 to 2 weeks, 2 to 3 weeks actually. So ghost cell glaucoma would appear typically after 3-4 weeks. There's a time it appears, and this has to be treated with topical steroids, not to be treated with topical steroids, because this is not to be confused with inflammatory kind of a glaucoma where you would need topical. So there's an important distinction to be made, and treat them with the systemic or topical anti-glaucoma medicine. And with time, this blood would go away and the glaucoma might settle down. But if it is intractable, then we have to do pars-plana vitrectomy and remove this blood from the vitreous so that glaucoma pressure comes down. So this case, we had a delayed rise in IOP, which is usually seen in ghost cell glaucoma, but it can also be steroid-induced glaucoma because many of these patients also receive steroid. So that has to be kept in mind. And also, if you have a lens injury, phacolytic glaucoma, phacoantigenic glaucoma, or severe inflammation after injury, synecdoche formation, all these factors would lead to glaucoma, which is a little delayed. And the treatment would depend on what exactly is going on. Is the inflammation, you have to cut down the inflammation. If it's a lens, you have to take care of the lens, and likewise. So this is 32 years old male, again injury, had an injury some 6 years ago. So this is a late presentation. So visual acuity is about 612, not bad, but IOP is 36 millimeters of mercury. So this patient was detected on routine examination actually, and you can see on the anterior segment this kind of unremarkable, except that you have an anisocoria and little bit of pupillary irregularity in the injured eye. But the gonioscopy here gives you the diagnosis. So you can see there's a angle recession, which is almost 360. You can see on the one side, there's the inferior angle. The superior angle is much more affected. And there's perhaps a little bit of cyclodialysis, iododialysis as well, small cyclodialysis there. So gonioscopy is very important here, and you can make a diagnosis of angle recession based on the gonioscopy. And because this patient actually came late, so already the disc damage is already happening. You can see there's a characteristic glaucomatous optic neuropathy here in the right eye. So we started him with the prostaglandin, and IOP was fairly controlled initially, at least.
So you have 1 minute remaining.
Required more drugs. So angle recession, as you knew, is kind of is a common condition, and 5 to 20% of the patient they will develop after trauma, and usually it presents 8 to 10 years down the lines. And the risk factors for developing angle recession would be the elevated IOP at the baseline, angle recession more than 180 degrees, trauma, hyphema, and increased pigmentation of the eye. So the mechanism is not very clear, but probably this because the injury to the tubular muscle or scarring, which happens because of the healing process. Management is typically medical, and most of these angle recession glaucoma, they will respond to medical treatment. But if they do not, then you have to do some, trabeculectomy or a glaucoma drainage device might be needed. So to summarize, high intraocular pressure following trauma is common. The prevention of glaucoma is the key because this high IOP is not glaucoma itself, but if the IOP really goes up, which can damage the optic nerve very quickly. So the timely and quick action is what is required here. And so early control of IO is very important. And if there's a hyphema, angle recession, or there's a lens dislocation or subluxation to the lens, so these are the people who are at higher risk of developing high pressure or glaucoma later on, and they should be looked at carefully and evaluated properly. That means include gonioscopy as well as indirect ophthalmoscopy. And also examination of the other eye is equally important because many times when you have a angle recession glaucoma, in half of these patients, the other eye also develops PUAG, probably because of some inherent predisposition to develop PUAG in these eyes. So that also to be kept in mind. Thank you very much. Again,
Thank you very much, Doctor. You actually covered it all. But one tiny thing we could add is the important risk factors which you suggested. Maybe if there's a presence of intraocular foreign body, maybe that also would be an added risk of the patient developing a high IOP. And a very, very basic thing. How would you differentiate a cyclodialysis cleft from angle recession?
I think gonioscopy by and large will give the clue. On gonioscopy, the cyclodialysis angle recession basically is the split between the cleavage between the longitudinal and the circular muscle bundles of the ciliary body. So when there's a when there's an angle recession, you are actually seeing the broadening of the ciliary body band. So because the face of the which is split now, that is more visible. But on the other hand, the angle recession, the spur will appear more whitish in that area. It will become more sharply defined, and you will have a little gap. The ciliary body band would remain the same.
Also, intraocular pressure being high would also be an indicator of
cyclodialysis. If a small cyclodialysis, the IOP may not change, but if it's a large cyclodialysis, yes, the IOP would be down.
Chitra, may I ask a question?
Yes, Dr. Agro.
Dr. Pandav, I'm quite intrigued by the fact that 50% of cases of angle recession would have a glaucoma in the other eye. Yeah. We have similar things in, say, Posner-Schlossman and pseudo-exfoliation, where the other eye has a greater chance. Yes. And there are times when I've seen that when we do a trabeculectomy in one of the eyes, where both eyes have raised pressure, the other eye also starts showing a reduced pressure. So what do you think is working? Do we know something about that?
I think it's not very clear, but I think in first coming to the 50% of the other eye showing high pressure. Now, typically these angle recession glaucoma, they actually appear 8 to 10 years down the line, even longer. There's a time they appear. Now it is probably, and later on, the other eye may develop PUAG. Now it is kind of a belief that these eyes inherently have a predisposition to develop glaucoma. So they would have developed PUAG in any case, even if there was no trauma. But because the trauma, now that the capacity of the clavicle mesh is actually reduces damage, so so that eye manifests glaucoma earlier than the other eye. So that's one of the thoughts which is there. But again, half of them do not, in half of the cases, the other eye do not develop glaucoma. So that is also true. So that means angle recession does predispose to glaucoma, but we have to keep in mind the other eye as well in these patients. And the other question was that if we do trabeculectomy in one eye for a high pressure, the other eye pressure also changes. Probably there is some kind of a neurological control which is there, which is not very well understood. But this phenomena is very well known that when you do a trabeculectomy in one eye, the other eye IOP could go up and down. So that's probably because body is adjusting both the ciliary bodies somewhat similarly. And if one is totally off, the other one might be affected. But again, we don't have a very good understanding about this phenomenon.
Thank you.
Thank you very much, Doctor.